All right, thank you for joining us today on Maximizing Reimbursement, Policy Coverage for Wound Care. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team. And I'm joined today by Mary Muko, and we're going to be your facilitators for today's event. A few housekeeping items before we get started. As I mentioned a little bit ago, on our website, you can find our training information. So we have a training center link at the top of the page of our website. And in there, you can find all things training, like upcoming events, training materials, encore presentations, etc. I want to remind you that our encore presentations that are on our website are generally there for about 60 to 90 days, but they're always available on our YouTube page until the information is either changed or updated. If you have any questions during today's event, you can place those questions in the chat and send it to all panelists. Finally, if you have any feedback about your experience today, there's going to be opportunities now to take our feedback survey. So Mary's going to place a copy of that survey link in the chat now, and we're also going to place it in at the end of the presentation. And that's just to assist you if you happen to need to leave the presentation early for whatever reason. You can go ahead and use that link and take our survey. Your feedback is very valuable to us. If you happen to be listening to this as an encore, we also encourage you to take the survey in the encore. So the encore survey link should be at the top left-hand side of this, or right-hand side of the screen. It's going to be a little eye with a circle around it, but it's also available at the end of the presentation and in the description as well. On your screen now is our disclaimer, which we have to give at every event that we host. Basically, our disclaimer says we prepared this information as a tool to assist you, our provider community. But know that Medicare laws, rules, and regulations often change. So it's your responsibility as a provider of Medicare services to make sure you are providing those services based on the current laws, rules, and regulations that are in place on the day of service that you provide them. So the basis of the answers and the information that we're going to give you today is all relevant as of today. But again, remember that Medicare, CMS, has final coverage determinations. So make sure you go to the CMS website for any current laws, rules, and regulations on the day you're providing services. We also ask that you please do not audio or videotape or screenshot this presentation. We are recording it for you, and again, we are going to put that on our YouTube page, and we'll also link it on our Encore page. This is our CPT copyright notice. Because this presentation happens to contain some CPT codes, we are obligated to give you the CPT disclaimer. And I do encourage you to read that on your own time. All right, so on your screen now is acronyms. These are some of the common acronyms that I may or may not, or Mary may or may not say during the course of this presentation. Now, Medicare's full of acronyms. So if we happen to use an acronym and it's not on this list and you don't know what it means, just go ahead and put it in the chat, and either Mary or I will respond to everyone and, define that acronym for you. All right, so why are we here today? Our objective and our agenda for today. Our objective is to assist our providers in lowering the denial rates upon medical review. And we're going to learn about the critical elements of wound care policy coverage, billing, and documentation. And to achieve this objective today, we're going to review policy coverage criteria for wound debridement. We're also going to discuss documentation requirements and review findings. And we're going to provide some insight into the billing and coding policy requirements. So let's start with coverage. We have an LCD. This LCD covers guidelines for wound care involving debridement, electrical stimulation, and even electromagnetic therapy, as well as negative pressure wound therapy, low frequency, non-contact, non-thermal ultrasound or mist therapy, and topical oxygen therapy. So our medical review team refers to this LCD for coverage criteria and documentation guidelines to make review determinations. I'll mostly be focusing on the debridement and related documentation today. But I wanted to let you know this title is linked for you. But I'm going to go ahead and take us out to the local coverage determination and just show you some of the information. So as I'm waiting for my screen to open, and again, that title is linked to local coverage determination, and that is L37228. So as a provider of wound care services, that is a WPS provider, I do encourage you to go out to the MCD database and learn, live, love this local coverage determination. Now, I linked directly to it, but I do want to show you a couple of ways that you can find this local coverage determination. If I back all the way up to cms.gov, I can simply do a search for the MCD database, and that'll take me to the database. I can also click under Medicare, and I can go under coverage, and I can go to the Medicare coverage database. It just depends on if you're a searcher or if you're a navigator. Two different ways to get to the same thing. Now in here, if I know the local coverage determination number, which I just copied from that previous slide, I could put it in here and hit search. I could also type in by keyword and do wound care, and I would look for a wound care LCD that is under WPS. So we're just going to go and let that search bring us to it. One thing I do want to make you aware of, when you go to a local coverage determination, make sure you are under the right local coverage determination for the contractor that you're billing to. We are your paying and processing contractor for Nebraska, Iowa, Kansas, Missouri, Indiana, Michigan, and we have some Part A coverage still sprinkled throughout a lot of the United States. So if we are your Medicare paying and processing contractor, you need to be following our LCD, not someone else's. You can verify that by clicking right here and just making sure it says Wisconsin Physician Service. All right, so as you scroll down in the LCD, it's going to give you a little bit of coverage information and policy information. And then it's going to go into the coverage guidelines and coverage indications and limitations and medical necessity. Now, I've incorporated this information into the presentation, but I wanted to let you know that this is where you should go and be reviewing all the information, the coverage criteria, the documentation requirements. This is what our review nurses use to review the wound care claims. So I am going to link back out to the presentation. And we'll go back and forth, you know, at various times into the local coverage determination if we need to. So moving on to the next slide, coverage basics. Debridement is defined as the removal of foreign material and or devitalized or contaminated tissue from an adjacent to a traumatic or infected wound until that surrounding healthy tissue is exposed. So again, that in layman's terms, that's removing the dead stuff, removing the icky stuff around on the outside borders of the wound until you can see that healthy tissue. So this LCD applies to debridement of the localized areas such as wounds and ulcers. The mere removal of secretions or cleaning of a wound does not represent debridement services. At least one of the conditions that are listed here on the slide must be present and documented. So these are also listed in our local coverage determination as well. So again, pressure injuries, stage 2, 3, or 4, venous ulcers, arterial insufficiency, some neuropathic ulcers, diabetic foot ulcers, etc. So should deep tissue pressure injury or stage 2 injury progress to unstageable, stage 3 or stage 4 that requires debridement, then the documentation supporting this must be included in the medical record. So I wanted to make sure that you were well aware of that. All right, so let's move on to standard wound care. And I apologize, sometimes my mouse double clicks and I don't know why. On our slide are some wound care standards. So these include things like optimization of nutritional status, debridement by any other means to remove devitalized tissue, maintenance of clean, moist granulation tissues, and appropriate dressing. And I bring this up because as you read the coverage criteria, we want to also make sure that some of the things that you're doing are standard wound care as well. So as you go through the local coverage determination, it will tell you that, you know, you have to do things that are standardized for general wound care. And so we're going to be looking for that in your documentation as well. So what are you doing to optimize someone's nutritional status? And this is really important when you have patients that are diabetic. Are we striving for and trying to help them achieve an optimal glucose control? Is that being done through optimal nutritional status? Are they getting enough proteins and macros that are essential to help with wound healing? Are they doing the things that they need at home to maintain that clean, moist wound with appropriate dressings if that's necessary? Do they have the means at home to keep a wound clean? So this is all part of your standard wound care and documentation that we're going to make sure that you are asking the patient about and that you are addressing. And if they don't have means for things like optimal nutritional status and good glucose control, what kinds of resources are we providing for that patient? Is there anything that we're doing to help with the home environment to help them achieve these things? And if there is, we would expect that you are documenting how you are trying to help or what resources you are referring the patient to or providing for them. So as we move on, let's talk about debridement itself. So debridement, again, it's defined as that removal of the foreign material or the devitalized, contaminated tissue from that adjacent to a traumatic wound until that surrounding tissue is, you know, healthy and exposed. So the goal of debridement is to remove that devitalized tissue and decrease the risk of infection. It's also done to promote wound healing and prevent further complications. So there's different methods that the provider can choose to use. What's important for you to know is you need to document the type of debridement that's being performed. As a review entity, if we choose your claim to be reviewed, like if you happen to go on a targeted probe and educate review for wounds issues or for wounds treatment, one thing we're going to look for is what kind of debridement are you doing? What's the method of debridement that's being performed? We want to know how much tissue is being removed, where the tissue is being removed from, and with what method. So on the next several slides coming up, we're going to talk about some specific components of debridement documentation. But before we move into different components, let's talk about the different types of debridement, including selective and non-selective. All right. So selective debridement refers to the removal of specific targeted areas of devitalized or necrotic tissue from a wound along the margins of the viable tissue. Occasionally, bleeding and pain may occur with this as well. So the routine application of a topical or a local anesthetic does not elevate active wound care management to surgical debridement. Selective debridement includes selective removal of necrotic tissue by sharp dissection, including scissors, scalpel, forceps, and the selective removal of necrotic tissue by high pressure water jets. So selective debridement should only be done under specific orders of a physician. Let's see, wound care non-selective debridement includes surgical debridement, and that is like excision or wide resection of all the necrotic or devitalized tissue, possibly including the excision of viable wound margins. This is usually carried out in an operating room by a surgeon. Anesthesia is usually required. It's frequently used for that deep tissue infection. Drainage of abscess, oh my goodness, my words aren't coming out, you know what I mean, or involved tendon sheaths or debridement of the bone. So sharp debridement is that removal of necrotic or foreign material just above the level of the viable tissue, and it's performed usually in an office setting, or it can be done at the patient's bedside, and it's usually done with or without a local anesthesia. So sharp debridement is less aggressive than surgical debridement, but has an advantage of rapidly improving the healing conditions of that ulcer. So these typically are the services of recurrent, superficial, or repeated wound care. And then enzymatic debridement is debridement with topical enzymes used by the necrotic substances to be removed from a wound, and these are things like protein, fiber, and collagen. So the manufactured product inserts, those contain the indications. They also should contain the contraindications, any precautions, dosage, and administration guidelines. So you need to make sure that you are following all of those things for your enzymatic debridement. And then finally, under the non-selective is your wet to moist dressing. So this type of dressing is used to keep your wound bed moist. This type of dressing is used to remove drainage and necrotic tissue from the wounds. So again, when you are doing debridement services, it's important that you are documenting what type of debridement you are doing and the manner in which it's being carried out. And then you need to tell us about what is done to the wound and the wound borders within that debridement services. As we move on to documentation, let's talk about a few documentation requirements. So first up in documentation is the documentation of a covered condition. So just as we presented at the start of this webinar under the wound care basics, the first thing that we're going to look for upon review is at least one of the covered conditions listed is documented. Now, if I go back to, slide, gonna move through quickly. All right. The coverage basics. So if I go back to this slide here, these are the documented conditions that we are going to look for. And these need to be documented in your notes. Okay, so I just wanted to refer back to that. So we're going to look to see if you have one of the covered conditions. We're going to next look for certified plan of care. So in your certified plan of care, there are several things that we're going to look for. Where is the wound at now? What issues did the patient have prior to wound development? What's the history? Like, what other treatments have been tried? How often is the wound care going to be done? So what's the amount, frequency, and duration? What are the goals of the wound care service? We're also going to look in there for descriptions of the wound. We're going to look for things like full, partial thickness, subcutaneous. We're going to look for muscle and bone involvement, etc. So if the services are going to be provided by a therapist, then the physician needs to certify the overall plan of care. So it kind of just depends on who is doing it, because very often you can have a like a physical therapist that will provide wound care. If the physical therapist is providing wound care, again, then the physician needs to certify the overall plan of care. So again, components of the documentation, the covered condition, the plan, and then these are some of the things in the plan that we're going to look for. One of the things is you need to let us know the potential to heal. So there needs to be ongoing evidence of effectiveness of your plan. That's part of some of the information that we're going to look for. We're going to make sure that the plan that you are putting in place really is the right track for your patient. So as the wound care happens week after week, we're going to see that you're moving forward into healing. And if things aren't working, if things aren't healing, what are you doing to change the overall plan for your patient? So ongoing evidence, again, of effectiveness of the plan is something that we're really going to be looking for in your day-to-day notes. But some of the additional components of the documentation are physician orders, physician progress notes, and then photographic documentation of wounds if it's applicable. Now, we understand that photographs are sometimes hard to send with documentation. Do the best you can. With electronic file transfers, a lot of times your photographs are easier to get through. We can get the color copy and we can see it. If not, I do encourage you to lighten it the best you can so we can see it. It's just part of the components of documentation that are necessary. So we need to make sure, you have that photographic documentation and you're providing that to us, in the best means possible. Treatment records. We, for documentation, are going to need all the treatment records that you provide. That includes things like wound measurements. We're going to need to know the wound measurements at the start of care and then your wound measurements before and after every treatment. So if we request documentation and we're looking at April, and let's say your wound care actually started in February, we need to have information from February, so probably your overall plan of care, or somewhere we need to see those overall measurements so we can see that the information that you are doing in April are still continuing to make treatment goal of wound healing. You're continuing to meet those things. So it's important, again, to make sure that whatever dates of service that we're looking at, we have measurements from the start as well. And then again, in your treatment records, the wound measurements, the debridement evidence, the tissue removal, the method to utilize, the characteristics of the wound before and after debridement. So what did it look like before you started? What does it look like after? Very often, a wound is larger after because of the debridement that was done. And that we know as reviewers is going to happen at time to time. So make sure that you are describing what you did, and then we have those measurements. We need to see the severity of the tissue destruction. Is there any undermining? Is there any tunneling? Is there necrosis or infection that's evident? Is there reduced circulation? Are we packing wounds? How much packing are we putting in? If there is things like undermining or tunneling, and can we see a decrease in the packing that's utilized, the length of packing material, when we go to the next or upcoming wound care treatments. And then finally on this slide is complicating factors of healing. What is inhibiting healing? If there's something that's inhibiting healing. And then what are we doing to help minimize that? We talked a couple slides ago about optimal nutritional status. Are we getting enough proteins? Are we getting enough of our other macros? Are we optimizing glucose control for our diabetics? Do we have a clean living environment? Is the patient carrying over with keeping clean materials and doing, clean or aseptic techniques to change dressings at home? If they don't have the ability to do that, what are we doing to help them achieve that? All right, so as we move on, and then again, any kind of contributory medical conditions. Do we have other medical conditions that are possibly inhibiting wound healing or making it difficult for the patient to heal at the optimal time frame that we thought they could? If they are, what are those medical conditions and how are they being managed? Are they being managed by the wound care physician? Are they being managed by the primary care physician? do conversations need to happen with a different physician or a different practice to make sure that patient is following through with things for that medical condition as well. And then finally on this slide is advanced beneficiary notices. So if they are issued, if they are applicable, you need to provide those in your documentation as well. So we can see them if you provide them. All right, a few expectations of documentation. So there is an expectation that we as your Medicare contractor have, as well as you should have for your patient, is that there's an expectation of improvement. So the goal of wound debridement are to remove that dead or devitalized tissue. You want to decrease that risk of infection. You want to promote wound healing and prevent any further complications. So again, there's an expectation of improvement that must be shown for Medicare to cover the services. So Medicare expects that with appropriate care, no extenuating medical or surgical complications or setbacks, wound volume or surface dimension should decrease over time, or wounds optimally will demonstrate granulation tissue. So wounds that fall into or that fail to demonstrate like measurable reduction in size at 2 to 4 weeks, despite appropriate therapy, those are really unlikely to heal. There is also literature to support that a reduction of less than 40% for venous and less than 50% for diabetic ulcers at 4 weeks is an overall predictor of outcome for healing. So evidence of improvement is really important for you to make sure that you document. And evidence of improvement includes those measurable changes or those decreases in size of some of the following things, like do we have decreases of drainage? Do we have improvements in the color, the amount, the consistency of that drainage? Is there decreasing or changes in the inflammation or swelling surrounding that wound? How about the pain and the patient's overall pain with the wound itself? Are we doing something to help with pain control? Is that pain decreasing as the wound is healing? We would also have an expectation that the wound dimensions, so the diameter, the depth, the tunneling, all of that those are decreasing. And then any necrotic tissue or slough is decreasing and improving. We also expect that wound care treatment plan to be modified in the event that the wound is not healing or optimal, optimal healing is not happening. So again, your debridement should be performed by a healthcare professional that's acting within the scope of his or her legal authority. So those people that have legal authority or within their scope to modify a plan should be doing so. If these things aren't happening, if we're not getting decreases in drainage and inflammation and swelling, then our plan may not be working. We might have to shift. If we shift, make sure you document it. It's okay to shift. It's okay to make new goals for your patient. We have that expectation that you would be doing that. However, if you do it and you don't modify your plan, we don't know why you're doing it. And we just may see something else that was never planned to be done, and it was going to make us question your documentation. So again, if you're shifting your plan, make sure you are documenting that you're shifting, and make sure that you are letting us know what you're shifting to. All right, measurable signs of healing. When thinking about supporting your measurable signs of healing, think about this always in objective and measurable terms. So measurements, including overall wound size and depth. Try to avoid subjective terminology. Saying a wound is smaller doesn't give enough evidence of healing to a reviewer. However, measurements that show a 3 millimeter wide wound is now 2 millimeters sure does. So we look for decreasing amounts of exudates from the wound, so amounts of drainage, type, viscosity of the exudates. Everyone should use consistent measurements within your wound care providers. Consistent measurements, scales to report, any types or amounts of wound cares, they should all be consistent. Perhaps everyone measures the amount on the bandage or the number of drainage changes that are needed on a daily basis, etc. Everyone needs to make sure they're measuring in the same way. Sometimes if a patient's in a facility, we have to educate the different caregivers to make sure that the way they are measuring is the same way as your wound care team is measuring. Because we often see documentation and it is, day to day looks a lot different. And it's hard for us to determine what's going on with this wound if, someone's saying something is serious and someone else is saying it's serosanguinous, and we don't, there's not a consistent description of the wound, the drainage, etc. All right. So let's move on with some of the review findings and errors. So in these next several slides, we're going to talk about the most common review findings and errors and how to avoid them. So the first thing is incomplete or insufficient information. This is one of the most common documentation errors. We just don't get the information that we need. We don't get the type of debridement that's being done. We don't get measurements. We don't have a plan of care or the specified components of the plan, or we don't have documentation of those required conditions. Again, I encourage you to go back and look at the LCD and look at the coverage criteria that's listed in the LCD. Do you have, appropriate diagnoses? Do you have goals of your debridement listed within your overall plan? Do you list the measurements, the drainage, the inflammation, the swelling, the way the wound looks, etc.? Again, all of this is spelled out in your local coverage determination. So make sure you are following that kind of stuff so you don't submit something that's got incomplete or insufficient information. Next is no debridement evidence. So things like the documentation did not show there was any tissue removal to support debridement was done. It's something that you might see as a denial reason. Or the type of debridement like sharp, enzymatic, etc. was not listed. If it's sharp, what type of instrumentation was used? Also, when we don't get evidence that the debridement was down to the subcutaneous tissue level. Additionally, lacking documentation of the wound before and after the debridement. So what did it look like before? What does it look like after? What did it measure before? What does it measure after? Finally, signatures and credentials of who performed the debridement services. So Medicare only pays when the allowable either physician, non-physician practitioner, therapist, that person that's acting within the scope of their practice and licensure does the debridement itself. So we need to make sure the appropriate person is there, therefore, or it's done the debridement, therefore we need to have the signatures with the credentials of who performed it. The next issue, and I touched on this a lot under medical review findings, is missing measurements. There should be no question, about this being a review finding, because I've harped on this so much throughout the presentation thus far. Without the pre and post measurements, we cannot assume that debridement was done. We cannot assume that the debridement that was done was reasonable and necessary. And it's helping to make improvements to the wound. So not only do we have to have the measurements, they must be marked as such. Are they pre, are they post? Often wound borders, again, are larger after debridement. So we can't assume that larger measurements are pre, because they could be post. We need to see depth. It must be included in the measurements. So every progress report should contain measurements pre and post debridement. That is, the place in the progress notes and in your daily treatment notes that we're going to most often look for to make sure that you documented it appropriately. We know that these measurements could be included in different places, so just make sure that you are doing them and you're documenting them every treatment day, and they must be included with your progress reporting as well. So your progress report should have a summary of what you have done, the measurements from the last progress report, how it looks now, etc. All right, next issue, missing plans of care and components of the plan. So there's a lot of findings that go into the plan of care. That's because there's a lot of components to it. So you need to submit the plan. Your plan needs to have frequency and duration. Your plan needs to have a detailed description of the wound. You also need to have descriptions of the patient's potential to heal. If they don't have a potential to heal and you're not going to show improvements, then perhaps the wound debridement and the wound care services are not what this patient needs. Perhaps they need to move to something like surgical intervention, like an amputation. If there's no treatment goals or treatment plans, and if there's no modifications to the plan when it isn't working. So these are all kinds of things that we have already discussed. And then incomplete goal information. You should document using SMART goals. Sometimes the reviewers are not seeing that it's specific or measurable or achievable or relevant and time bound. So that's kind of what your SMRT falls under. So specific, achievable, or specific, measurable, achievable, relevant, and time bound. If lack of progress, again, how are you changing that goal to get through that and make progress for your patient? But again, incomplete goals are sometimes what can cause a denial of your service. And then missing complicating factors and methods to control. So another issue, again, that the documentation is lacking, those complicating factors, the methods that are being used to control the wound healing. And this goes back to what I discussed with things like optimal nutrition and any medical conditions that may inhibit your wound healing, like diabetes or even CHF, or perhaps unsafe living conditions. So make sure these are documented as well, because they could contribute to the denial of your claim review. And then finally, missing conditions of coverage. And we went back to the LCD and we looked at this LCD and we laid those out several times. So make sure you are reviewing that local coverage determination and going back to this LCD and making sure you are documenting it appropriately on your, not only on your claim, but within your documentation. So at this time, I'm going to turn things over to my friend and colleague, Mary Muko, who's going to go through some of the billing and coding guidelines. Mary?
Good morning, everyone. I'm so happy to be able to spend some time with you today and talk about the billing and coding guidelines. Now, Mary Sue just walked through, I like to call it walking through, our local coverage determination. But billing and coding guidelines are different than the local coverage determination, but they go together like peanut butter and jelly. Billing and coding articles are the companion to a local coverage determination. We call those LCDs. Sometimes the billing guidelines are called by different names. Most of the time, CMS and many of us MACs, Medicare Administrative Contractors, will refer to these as articles. And you can tell if it's an article versus an LCD by the identification number. Look at the slide that is showing right now. It says Article A55909. A means it's the article that accompanies the policy. You can see that on this particular slide. I've added a link to the WPS LCD. The ID number for our wound care LCD is L37228, and that's what Mary Sue just talked about. Now, it is very important that providers not just refer to that local coverage determination, but also refer to that companion article, because that information will help make sure that you are submitting compliant claims and you're receiving that proper payment or that proper reimbursement. Now, billing and coding guidelines are not the same as billing and coding advice. People mix those up. Now, MACs, Medicare Administrative Contractors, including WPS, are actually prohibited by CMS from offering coding advice. Now, this means that we cannot choose a code for you to report on your Medicare claim. One of the questions that came in the chat was actually someone that said, when we do this, do we report this code? I can't tell you that. Number one, I don't have your documentation, so I can't tell what is actually or what was rendered and what's documented in those medical records. But I just, we can't give you a code to report on a claim. We can't say, yes, that's the correct code. But we can offer billing and coding guidelines as a companion article to our local coverage determinations. Now, so far, I believe I have been able to respond to all of those questions out there, other than one, Mary Sue, that came in at 10:28. It's about nurses, so you want to put a little flag up, and we'll revisit that one in a little bit. But right now, I am going to continue talking about the billing and coding article that accompanies our LCD. Now, based on CMS directions, it is not appropriate to include CPT codes or diagnosis codes in the actual LCD. Now, this is just one more reason why there is that companion article, the billing and coding guidelines, that goes along with that policy. Remember, peanut butter and jelly. Now, Article A55909 is titled Billing and Coding Wound Care. It addresses only the procedure and diagnosis codes related to WPS's LCD, in this case, L37228. So for Article 55909, there are actually two different sets of CPT and HCPCS codes. They're identified by Group 1 and Group 2. That's what we call them. and the respective Group 1 and Group 2 diagnosis code lists that WPS says supports medical necessity. So for Group 1 CPT and HCPC codes, use the Group 1 diagnosis codes. For Group 2 CPT and HCPC codes, you use the Group 2 diagnosis code. Now, the fact that a code appears in the billing and coding article does not imply coverage. The service, of course, must meet all coverage indications and limitations that are described in that local coverage determination. The services, of course, must also be medically necessary and otherwise covered by Medicare. And sometimes people say, well, what do you mean by that? What does otherwise covered by Medicare mean? It means that the services were, for example, performed by an eligible provider for an eligible patient or eligible beneficiary, and so on and so forth. So in addition to medical necessity, all services for Medicare must meet coverage, other coverage requirements as well. On the next slide, there is mention of something that Mary Sue talked about a little bit when she covered the policy, and that is negative pressure wound therapy, or NWPT. The article, those billing and coding guidelines, includes coverage guidelines. Now, the first guideline in that companion article pertains to NWPT. Now, based on the Social Security Act, Medicare will cover NPWT devices, units, types of supplies, but they're covered under the Durable Medical Equipment, or DME, benefit. So this means that providers that are seeking to bill for this would need to consult the DME Medicare Administrative Contractor for their specific coverage. Those claims would not be submitted to WPS, but to the DME MAC for that particular provider's jurisdiction. Now, on the next slide, we've included some codes, and these are actually taken right out of that billing and coding guidance. It's specific to certain codes. Sometimes we have coding guidance for specific codes. Now, the codes are listed here on this slide, along with a description of each, beginning with 97597, debridement, first 20 square centimeters or less. Similarly, there's the 97598, which is used to report each additional 20 square centimeters of debridement. And then we have the codes for sharp debridement, which of course, and based on the guidance in the coding guidelines and what I've placed here on this slide, this is more aggressive. It does remove deeper tissue, and the code depends on the depth of the tissue removed and the surface area of the code. And those codes are 11042 through 11047, or 11042 through 11047. The next guideline in that article that I'm talking about today is hydrotherapy. It says right within that guidance that the first form of wound care addressed in the guidance, excuse me, let me back up. The first form of wound care that's addressed by is hydrotherapy, that being in the guidance. When a therapist reports CPT codes 97597 or 97598. Now, the article states that what Medicare will be looking for is that the record would show that the skill of a therapist was required to perform the service for the specific or given situation. Now, if this isn't included in the documentation, that service would be deemed as not meeting medical necessity requirements. I'm talking about the article. Mary Sue talked about an LCD. Remember, policies equal edits. There are edits within the claims processing system when certain CPT codes are submitted to Medicare, and that would then apply the computer logic in order to make certain that that particular claim item is indeed medically necessary and coverable based on the policy itself. So anytime there's a policy, that means there's an edit. So when these codes come through the claims processing excuse me, the claim processing system, they're going to pop up in an edit. And we're going to need to make certain that other information submitted on the claim does justify medical necessity and coverage. And sometimes, not always, Medicare will request the documentation in order to make certain that the service is payable based on Medicare guidelines. Now, the next modality in the article is covered on the next slide, and the article states that Whirlpool 97022 may not be separately billed with CPT codes 97597 or 97598 unless the Whirlpool is provided for a different body part than the wound care treatment body part. Now, how will Medicare know that when these CPT codes come along? You would need to report an applicable modifier in order to let Medicare know that it's a different body part than the wound care treatment body part. So you would use a modifier to show this, and we do have modifier fact sheets available out on our website, many of them. For most of the modifier fact sheets, we will include not only the description of that particular modifier, but we're going to show appropriate uses and also some inappropriate uses, and sometimes we'll include a CPT or HCPCS code range or a list of codes for which that particular modifier is available to report on a claim. On the next slide, there is some mention of the guidance in the article that addresses local infiltration. We state in our guidelines that local infiltration, such as those listed here on this slide, I'm not going to read through the list, you can see them up there. It's included in reimbursement for debridement services. So as such, this is not a separately payable service. And for the same reason, administration by or incident to the individual who rendered the debridement is also not separately payable. So what this means is that you would not be able to bill the beneficiary for these bundled services. On the next slide, there is mention about the guidance that addresses codes that are considered as sometimes therapy codes, that being specifically CPT codes 97597 and 97598. Once again, these are the examples. When billed by a therapist for a patient who is receiving home health benefits, these services would then be covered under that home health benefit if they are part of the home health agency's plan of care. In that case, WPS wouldn't be processing those claims. It would be the home health MAC. When billed by a physician or non-physician, these services are paid under Part B, even if that beneficiary is under an active home health plan of care. In that case, you would submit those services to the MAC or to WPS. The next slide talks about CPT code 97602, and this is a unique there you go, Mary Sue, is a unique code because it is one that's actually listed with a B status on the CMS relative value file. The relative value file is listed out on the CMS website, and I can get to, if you hang on just a second, I'm going to pop that into the chat for you. See if I can type while I'm talking. I did have a few typos earlier, I noticed, moving quickly through the chat, so I apologize for those. But 97602, wound care, non-selective, described as a procedure performed to remove dead or damaged or infected tissues, is what CMS deems as a bundle procedure, and that means it is never payable by Medicare. So if you go out to that physician fee schedule relative value file, and I've embedded the link in your presentation materials, you'll see in the status code for that particular CPT code that there is a letter B, and a B on that CMS relative value file means that the service is bundles. It's always bundled. You will never be able to receive separate payment for it, nor can you bill the patient for this. There is no modifier to override this particular edit. It's hard-coded. It's not a covered service because it's always bundled. On the next slide, there's some information about infrared. Another type of wound care mentioned in our article, of course, is infrared, reported with CPT 97026. And based on a national coverage determination, the number is linked, or the NCD is actually linked here on this slide and in your presentation materials. It's 270.6. The name of it is Infrared Therapy Devices. Based on this national coverage determination, which applies to all MACs, unlike a local coverage determination that applies only to a single MAC, this service is never covered by Medicare. So since this is a national coverage determination, as I mentioned, it applies to all MACs, not just to WPS, but Medicare is never going to pay for that CPT code and 97026 for infrared. CMS determined that there is sufficient evidence to conclude that the use of these therapy devices and any related accessories are not reasonable and necessary under the Social Security Act. And that Social Security Act, of course, states that the overarching criteria for Medicare payment is medical necessity. So Medicare will not pay for that. And it includes the treatment of symptoms such as pain arising from diabetic or non-diabetic peripheral sensory neuropathy, wounds or ulcers, and also ulcers of the skin and or subcutaneous tissues as well. The next specific modality that's discussed in the guidelines, I keep wanting to say local coverage decision, but in the billing and coding guidelines is ultrasound. So the billing and coding article also addresses this. Ultrasound for wound care and phototherapy, ultraviolet modalities. These would be those reported with CPT codes 97035 and 97028. Based on the LCD, L37228, WPS will not pay these codes for wound care. Remember those edits. So how does Medicare know that those services aren't covered? They're hard-coded edits for those particular CPT codes, so that when the claim comes in through and is moving through that claims processing system, those codes are going to deny because the policy states that they're not payable for wound care. So the next slide then addresses reporting of codes 11042 through 11047. This is debridement of wound before topical or local anesthesia is applied. The coding guidelines do explain how to report the service using the depth of the wound, specifically for a single wound. Choose the code based on the depth of the tissue removed and by the surface area of the wound. For multiple wounds, the guidelines state that you're going to sum the surface area of those wounds that are the same depth. Don't combine sums from different depths. Choose the codes based on the depth of the tissue and the combined surface area of the wounds with the same depth. So for an example, for 3 wounds, let's say 2 of them are at one depth and 1 is at another depth. What you would do is combine the surface area for the 2 areas at the same depth and choose the code. Then you'll separately report the code for the remaining surface area at its depth. Next, on the next slide, what you're going to find is more coding guidelines that are taken from A55909. It states there, do not report 11042 through 11047 in conjunction with CPT codes 97597 through 97502 for the same wound. Excuse me, I misspoke. It's 97602. I apologize for that. Wound care services can be provided in a variety of settings, each with its own specific place of service. WPS, according to the guidelines, will consider these codes 11044 and 11047 for reimbursement, but only when billed in an outpatient or inpatient hospital or ambulatory surgical center, or ASC. In other words, only when certain places of service codes or place of service codes are reported. We do have the listing of place of service codes available out on our website. CPT codes 11043, 11046, 11044, 11047, listed there on that bullet on the right, are codes that describe deep debridement of the muscle and or bone. So just some more coding guidelines. And finally, on the next slide, and it's actually in the last section of the billing and coding guidelines, there is a list of a couple of other reasons for denial. Shown here on this slide, of course, the guidance says that performing bony debridement in place of services other than inpatient hospital, outpatient hospital, or ASC could be a reason for denial. Also, billing of debridement by unqualified personnel. Whenever personnel within an office is rendering a service, you want to make certain that they're performing only those services based on their state scope of practice. Sometimes Medicare has even more strict guidelines than looking at state scope of practice, but that of course would be in billing and coding guidelines. But you'll want to be aware that you'll need to meet those licensing or certification requirements based on state scope of practice. So that brings me to the end of my prepared remarks, but I do want to show you how you can get to the billing and coding guidelines. Mary Sue, can you show that? And if you showed it already, I'm sorry, I had my eyes buried in the chat. If you showed it, I would just want to remind folks how you can get to those billing and coding guidelines. Mary Sue summarized the LCD itself. My part of today's presentation was to present for you those billing and coding guidelines. So in most all local coverage determinations, not just WPS's, but other MACs also. Near the end of the policy, there's typically a link to those billing and coding articles. Mary Sue, can you please click on contractor information? You know, when you're out opening a lot of documents or looking within the Medicare coverage database, one thing I do want to make certain that you're aware of is that there are these drop downs within these LCDs and coding and billing guidelines that are in the Medicare coverage database. I know some of you likely bill for more than one MAC. You know, make certain that you're following the guidance that is specific to where those services were rendered. So make certain you're following Wisconsin Physician Service guidelines when it is a service that's being rendered within our MAC jurisdiction. For those of you not familiar with our jurisdictions, it's Iowa, Kansas, Missouri, Nebraska, and Indiana and Michigan. Part B. For Part A, we're in nearly all states across the country and part of our Jurisdiction 5 contract, and also in Indiana and Michigan. So make certain you are looking at the correct contractors' policies or local coverage determinations and articles when you're out there looking for that specific advice as to what that particular MAC will or will not consider as medically necessary and covered by Medicare. All right, at this time we do have just a couple of minutes left for some questions and answers. Mary Sue, I don't know if you've been able to keep up with them as they're coming in. If Mary Sue didn't answer your question in the chat or I didn't, I'll tell you in just a few minutes how you can submit those questions to us.
Mary, thanks. You know what? There were several questions that came in, and I'm going to give an answer. I put a general answer into the chat, but I'm going to give a general answer on the audio portion of this call, and it was regarding E&M services, you know, on the same day as the debridement charges or the wound care charges as well. And the basic thing I want to state about this, and Mary can add any information, you know, when I get done, is think of them as two separate services. You can't double dip your wound care services with your E&M. So it's got to be separate and distinct. So if you took away all of the documentation that had anything to do with that wound care service, do you have enough information left that would support the level of E&M code that you wanted to bill. If then you do, then it's possibly something that you could report on that same day. So Mary, did you have anything that you would want to add about that?
No, I think you did a good job explaining that. That's a very, very common question. You know, when can we bill the E&M in addition to the procedure that's being rendered? I like your description or your answer that, you know, the documentation would need to stand alone and justify that the services were medically necessary and otherwise covered by Medicare, as well as rendered and documented appropriately in those medical records. And you can't double dip, you know, it can't overlap those services. If you're billing an E&M service, there needs to be evaluation and management, or evaluation and management service. You know, remember that there is part of the reimbursement for any procedure based on the Medicare physician fee schedule, is looking at that wound and you know, evaluating it and such. So there's, you know, a portion of that already built in. So the documentation does have to show and stand alone that the services were significant and separate. All right. Well, we have 2 minutes left, folks. Thanks, Mary Sue. And thanks to all of you. You submitted some great questions. And in just a minute, I'm going to tell you about how we're going to respond to any questions in the chat that we have not yet gotten to, or those that are sent as a follow-up. If you're like me and you go to some training and you're listening to what's being shared live, sometimes we don't always think of a question. We do when you know, we're working, or the next day a question will hit you and you say, I wish I would have asked that while I can. Well, you'll have a chance to do so for a week. First of all, though, I want to go ahead, Mary Sue, talk to you a little bit about a process change that's coming up. This is effective August 4th. If you have been receiving our e-news and if you've been reading it, very important to read it, to receive it and read it, you'll know that effective August 4th, our customer service folks have a process change where they will respond to one P10 NPI combination per call. The reasons why we're doing this are in those articles we've sent out and also listed here at the bottom of the slide. So we want you to know that's coming and happening, so be prepared. If you have more than one NPI P10 combination, you'll have to make a separate call for it. On the next slide is a place where we are telling you why it's so important for you to complete the brief survey that's going to be offered to you at the end of this webinar in more than one way also. We are committed to making those changes based on your wants and your needs. We look at every single survey that comes to us, and we also make changes. A couple of the changes that we in provider outreach and education have made recently were that we've added chapters to the YouTube descriptors. So if you go out to a YouTube video on our website, you'll be able to, not our website, on our YouTube channel, you'll be able to look at those chapters. It's a beginning time and an end time, and you'll be able to move throughout that video. So if you want to listen once again to information on some of those CPT codes I talked about today, you can move right to those billing and coding guidelines instead of going through the entire video. That's just one of the changes. The other is the addition of training indicators to those descriptors for our webinars, and that's done so that those of you within offices and organizations know when the information or the content that we're covering within a webinar pertains to you. Does it pertain to coders? Does it pertain to billers? What about compliance staff? So that's what those training indicators are about. We tell you who it may be most helpful to. The next particular slide then addresses our certificate of achievement. Shortly after this webinar concludes today, you will receive, those of you that didn't join only by phone, and I'll talk about that in just a minute. Those of you who didn't join only by phone will receive a thank you for attending email. It is sent by WebEx. The words within that email itself serve as your certificate of achievement. There is no separate attachment. What it will look like is on the left side of this particular slide. There's a red box there. It says Certificate of Achievement. We'll have your name, today's date, the contact hours, which I think was 1.25 today, not just one. We had a lot of information to share with you, but that, folks, is your certificate of achievement. You'll take a copy of that email and get it over to the accrediting body of your choice, and they will consider awarding you with CEUs. WPS does not directly award CEUs. We give you the certificate. It's actually WebEx sending it out to those of you that didn't join just by phone. Now, what about those of you that did join only by phone? You're listening only to us today. You're following along in your handout. You're not seeing the slides that Mary Sue has been showing. Those of you that joined only by phone will need to submit an email to our education mailbox. And I'll ask Mary Sue to pop that once again into the chat for you. We've mentioned it a few times today. For those of you listening, it's wps.gha.education@wpsic.com. Tell us today's date, the name of the program, wound care is good, and the telephone number that you called in from, and we will verify your participation, and we will get you a manual certificate of achievement, and that will be an attachment. Next up, just before we conclude today, I do want to talk about follow-up questions. I've mentioned them a couple of times today. You have 7 days from today, actually noon, 7 days from today, to send any follow-up questions, presentation related questions only, please. If it pertains to another topic, we'll not be able to answer them in this way, but you can send claim-specific questions or non-presentation related questions over to customer service. Mary Sue and I do not have access to any claims history, so we can't go in and look at what happened to a claim during processing. So those claim specific questions have to go over to customer service. If you have coding questions, and I saw a few of those out in the mailbox and those that were submitted as a pre-submitted question, how do you code this? How do you code that? Remember that we're prohibited from offering coding advice. We can give you a coding guideline, but we cannot select a code for you and tell you this is the code you need to report on your claim. Next up is just a reminder about the survey. If you've been to any WPS webinar or a webinar from any other Medicare contractor, you will have heard how important your feedback is. We want your opinion. We want to know, what can we do better the next time? What did you really like about what we did today? Do you have a wish list of other topics, things other than wound care that you'd like us to educate on? All of that great information from you can be shared with us by this brief online survey. So please do complete the survey. Yes, I am begging. We would like to see all 62 of you complete that survey. I'm looking at the participation list here, 62, well, minus Mary Sue and myself, so 60. We would love to get 60 surveys back today. Be the group that returns the most surveys. We know and we care about what you need and what you want, and we want to make it happen if we can. All right. We'll give you an opportunity to take that survey if you've not already done so. When you leave today's webinar, there's actually going to be a window that pops up that will allow you one more opportunity. It's going to look like what you see on the bottom of this particular slide. There's a little yellow triangle at the top. What that is a pop-up that says you're leaving this website, you're going to the CMS website for a survey. It's not malicious. It's okay to hit the blue button and continue if you've not already taken that survey so that you can get your important message over to us at your wants, your wish list long before Christmas, right? All right, with that, we did go a little over. I apologize. We know how busy you are. On behalf of myself and Mary Sue and all of Provider Outreach and Education, thanks for attending today. You may now disconnect from this webinar. Thanks, everyone. Have a good one. Stay cool.
you.